Welcome you all to the session of endocrine and cancers. This is the joint session by PES, ACE, MENA, and ICE. To chair the session, I would like to invite the renowned consultant endocrinologist, Professor of Diabetes and Endocrine, Hayatabad Medical Complex, Peshawar, Project Director, DTOC KP, Chairman, KP Task Force Diabetes, Vice President, SAFIs, past President, ACE Pakistan, and past President, Pakistan Endocrine Society. Welcome you, Professor A.H. Amir. Kindly take the seat, sir. We have another chairperson, Dr. Gulshad Hassan, consultant endocrinologist, Bahria International Hospital, Lahore. Sir, are you here? Is he here? Yes, sir. Sir, kindly come to the stage and take your seat. Today's first talk is Managing Adrenocortical Carcinoma, Challenges and Strategies. For this talk, I would like to invite the honorable guest speaker, Dr. Sina Jasim, who is the Associate Professor of Medicine and Endocrine Neoplasia Specialist at Washington University. She's from the USA, Editor-in-Chief, ACE Case Report Journals. She was awarded Rising Star in Endocrinology by the American ACE Association of the Clinical Endocrinology. Please welcome to the stage, and it's over to you.
Good afternoon. Assalamu alaikum. It's a pleasure to be here, and thank you for inviting me to be part of this year's meeting. It's a pleasure and honor, and if there are any issues or mistakes, please pardon I'm still in jet lag, so but we'll try to get through this together. I'm part of ACE, I'm representing ACE, and as mentioned, I'm ACE Clinical Case Report Editor-in-Chief, so later on I'll be walking around and inviting some submission to our journal. Curious to know how many in the room are endocrinologists? By show of hands. Okay, any oncologists? Surgeons? Radiologists? Okay, good. I have no disclosures other than the part that I just mentioned. And our objective today is to review the epidemiology and clinical features of ACC, adrenocortical carcinoma, and discuss the differential diagnosis of ACC, potentially what make adrenal mass malignant, and summarize the current treatment options for local and advanced disease. So we'll start by a case, a 60-year-old woman with incidental finding of hormonally silent left adrenal mass. And you can see it here. So when we see a mass like this, the questions comes in mind. I already said hormonally silent, so the first question sometimes is there any hormonal production? Is it adrenal or extra-adrenal mass? Is it benign or malignant? What's the potential for malignant transformation? And these are typically the questions we ask every time we evaluate patients with adrenal incidentalloma, so to speak. So from epidemiology perspective, luckily ACC is pretty rare. It's about 1 case per million per year. For some reason, we call it the founding effect. They are much more common in Brazil and in children. The sex distribution is almost equal, with some predominance in women over men. And as far as the age distribution, it's bimodal in the first and fifth decade in life. And if you look at the epidemiology here, it's still adenoma, non-functional adenoma, take the vast majority of adrenal nodules. And luckily, ACC is less than 5%. So when size is larger, when we talk about adrenal masses that's larger than 4 centimeter or larger than 6 centimeter, then the risk of malignancy is much higher. So if you look at the epidemiology here, for anything less than 4 centimeter, it's still benign. But as the sizes start enlarge and we're getting to 6 centimeter and above, then you see not a significant number of that can be ACC. So size is always important. When it comes to why people develop adrenocortical carcinoma, it is hard to tell. It's multifactorial, but it could also be part of genetic syndrome. Some of the syndromes that we're familiar with that can lead to ACC is Lifromini syndrome, which is TP53 mutation. We see that mainly in pediatric. We're all familiar with multiple endocrine neoplasia, type 1. And then Lynch syndrome, Carney complex, neurofibromatosis, and even congenital adrenal hyperplasia, and many more. So it's always when you see a case of ACC, it's important to evaluate for genetic syndromes. So let's talk about evaluation. And the first step in our evaluation for any adrenal mass, including ACC, is imaging. So this is a 66-year-old male with a 7 centimeter right adrenal mass. On non-contrast CT, it's indeterminate with irregular border. And you see the nodule here. And you see the irregular border here. This is a 7 centimeter right adrenal mass. With non-contrast CT is indeterminate. You wonder if there is invasion here, right? It's touching the liver. It's kind of like very close to the inferior vena cava. You do hormonal workup, like any astute endocrinologist, and it's negative. But you see how it's invading and touching the liver. So this is, everybody see this. You don't necessarily think of it as benign adenoma. It's a heterogeneous mass. And the size, like I mentioned, heterogeneity is always a concerning feature. So the most current guidelines that publish on adrenal incidentaloma by the European Society of Endocrinology is actually published just recently this year. And they updated some of their practice guidelines. And so the recommendation for any adrenal mass, 4 centimeter or above, and heterogeneous, and has unenhanced house field unit more than 20, you should be suspecting malignancy in these cases. And a multidisciplinary discussion should be done to evaluate for surgery. Now, if you're suspecting ACC, it is not recommended to biopsy that mass, of course. And prior to surgery, we like to know about staging. And so at minimum, we want to get a CT chest to make sure there is no lung involvement, which is the most common site for metastasis, and sometimes FDG PET as well. And this is their current schema as far as the workup for adrenal incidentaloma and when you suspect malignancy and what kind of images you want to do. So here it says if it's heterogeneous with house field unit more than 20, tumor size more than 4, or even heterogeneous and tumor size more than 4, you want to consider evaluation for ACC and consider staging. So to summarize, and this is actually a paper that was published by ACE in 2020 regarding the evaluation of ACC, some of the imaging characteristics that make you worry about ACC versus benign adrenal adenoma or other types of adrenal adenomas. The size, like I mentioned repeatedly, larger than 4 centimeter, irregular shape, irregular margin, heterogeneous mass, calcification, necrosis is common, hemorrhage as well. Growth is rapid, so if you decided that you monitor that mass in 6 months or 1 year follow-up, it might be much bigger. The Hounsfield unit is definitely more than 10, and in fact, it's definitely more than 20 or even 30. So 10 is kind of like arbitrary. If it's less than 10, it's almost always benign. If it's more, then it's questionable. But when we're talking about cancer, it's actually 20, 30, or even more. And then the absolute washout is less than 60%, and the relative washout is less than 40%. And that's when you compare the non-contrast with the contrast. MRI, the chemical shift, there is none because it's lipid poor typically. And if you do FDG, you don't have to, but if you do PET, it will be avid. As far as evaluation, more or less all adrenal incidentaloma should be evaluated the same. But if you're suspecting Cushing syndrome, for example, 1 milligram dexamethasone suppression test would be appropriate. If you're suspecting hyperaldo, run-in aldosterone levels would be appropriate. If there is hyperandrogenism, of course in women, you check DHEA sulfate and testosterone. And if there is any feminization, estradiol. Additional labs like the general lab, CMP, BMP, these are all useful. So the European guidelines summarized it into essential for clinical diagnosis or care and non-essential for or potentially useful or informative. And so whatever is essential here is what I just mentioned. And these are the standard. The non-essential, but it could be informative, and it's not always available, is the metabolomics, steroid metabolomics. You check the androstenedione, 11-dehydrocortisol, 17-beta estradiol, all the metabolites. And there's nice papers that summarize what metabolites can go with malignancy versus benign. But I understand that's not always available, even in the United States, and sometimes we have to send it to Mayo Clinic. It can be very informative in cases that it's not really clear if it's cancer or not, and you don't want to do a biopsy, of course. ACC pathology, you look at Weiss score, which basically look at high mitotic rate, atypical mitoses, high nuclear grade, low percentage of clear cells, necrosis, diffuse architecture, capsular invasion, sinusoidal invasion, and venous invasion. Each one has a score, and if the score is a 3 or more, that's consistent with ACC. So you can agree with me, diagnosing ACC requires a really good pathologist because it could still be controversial. And these are actually the summary of these score, and each one has 1 point, and then you calculate it. And technically, that's how pathology really decide this is adrenocortical carcinoma. Additional feature in addition to that is the tumor size, the surgical margin, if you see a lymph node, but that's after the fact during surgery. And of course, if there's metastasis and some of the immune histochemistry stains. Genomic profile, since the publication of TCGA data in adrenal cancer, we know much more about the molecular aspects of adrenocortical cancer. Not exactly like thyroid cancer, when a lot of these pathways actually were used as target therapy for thyroid cancer. It was not as advanced and successful in ACC. But we know the most common pathways in adrenocortical carcinoma is TP53 mutation and Wnt beta-catenin signaling. And actually, it's very helpful in staging patients and in prognosis. So patients who have more mutation, they're more likely to have worse outcomes. So now we're talking about outcomes, so we're talking about prognosis. The most important thing in prognosis is the staging. Whether you use the ACC or AJCC staging, or you use the NSAT staging, the European, it's pretty much the same. So data showed for patients who have stage 1, their 5-year survival is more than 80% versus less than 13% if staging is 14. And this is mainly metastatic disease. The other thing, you might want to ask the pathologist to stain for the Ki-67 if it's available. And actually, this also correlates with the prognosis. If it's more than 20, it's definitely worse prognosis in comparison to less than 10. And then, of course, hormonal overproduction. So there's data says if the tumor producing cortisol, it's more likely to be aggressive. And there are some data showing that. So this is the hormonally active here. And we actually just had a paper accepted in Journal of Surgery in the American Association of Endocrine Surgeons that basically it's a multi-center study that looked at all cases, more than 1,000 cases of adrenocortical carcinoma nationwide. And if they actually producing cortisol or producing androgen, they have worse prognosis. And if they produce both, which make you suspicious of adrenocortical carcinoma, if a tumor produces more than one hormone, then actually it's worse prognosis. And here become the role of an endocrinologist is very important because you want to diagnose this, not just because the disease is aggressive, but because if you treat that patient surgically, the patient will have issues with adrenal insufficiency if the resection was complete. The other issue that affect prognosis is the resection. So the best bet to treat a patient with with ACC is surgery. And you might want to have the surgery done right from the beginning. What I mean, R0. So R0, which is clean margin or negative margin, have a better prognosis if they're picked up early compared to R1 or RX. All right, management of localized ACC. This is another case of ACC with Cushing syndrome. 6.5 centimeter. So in these cases, there's a preoperative management that you're diagnosing the hormonal evaluation if the patient have probably hyperglycemia, hypertension, and all of the electrolyte disturbances, and then the surgical management. And the debate always open versus laparoscopic adrenalectomy. And this is very debatable anywhere in any institution and depend on the quality of the surgeons and what they prefer. But the recommendation in general in cases like this is to have open adrenalectomy. Adjuvant therapy, we're talking mitotain plus chemo, chemotherapy alone, or radiation, and surveillance. So here, emphasizing that you're trying to get R0 resection. And really the best hope here is to have open adrenalectomy because you don't want a 7 centimeter tumor to be resected laparoscopically unless in the hand of excellent surgeon because the risk of spillage is much higher. Now, some people ask, is prophylactic lymphadenectomy would help in the prognosis or improving survival? And the answer is yes, but the data is limited. Technically, there's only 1 or 2 studies that looked at that. And they mentioned 2/3 of ACC patients will have metastasis at the time of diagnosis or surgery. So it might be useful to remove those lymph nodes because lymph node metastases are predictor of long-term poor outcome. So in this particular study that was published in 2016, they recommended to do lymphadenectomy. One of the biggest centers in US that deal with ACCs, University of Michigan, they usually do that. Other places, they don't always do that. Now I'll talk about mitotain. So mitotain is an adrenolytic agent. It's been in the market since the 1960s. It basically kills the adrenal tissue, the cancer and the normal. And so the interesting part of it is a CYP3A4 inducer. So it could interact with a lot of other medication as simple as a statin. So this is very important, and even as simple as a steroid, because patients who start on mitotain will have adrenolytic effect, will develop adrenal insufficiency. You put them on a steroid, but in this case, hydrocortisone will not be a physiological dose. It would be 30 or 40 or more because it's rapidly metabolized by this medication. But the outcome is actually good. And we aim usually to start at 1 to 2 grams a day. And we manage by looking at the serum level of mitotain, which has to be more than 14. The issue, however, is not easily tolerated. It can actually have symptoms of adrenal insufficiency, fatigue, but plethora of other endocrine and non-endocrine side effects. This study in particular looked at the use of mitotain versus surveillance in low-grade or low-risk localized ACC. They defined this as ACC stage 1 to 3 with complete surgical resection, R0, K67 less than 10%. So we call that low risk. Now we know all ACC is high risk, but this is in the field of ACC. And they compared patients who had mitotain versus observation. And at the same time, there was a simultaneous study that looked at observational data to look into people who randomly went to, it wasn't a randomized trial, but it was observation study who went through either observation or mitotain. And actually there was no difference, whether you use it or not use it. The 5-year recurrence-free survival was similar. So based on that, the current recommendation is not to give mitotain if the adrenal cancer has a low risk and K67 is less than 10. What if it's more than 10%? What if it's slightly higher risk? There is ongoing trial now that looking at this, which is mitotain with and without chemotherapy, looking at a little bit more advanced cases of adrenocortical carcinoma, and it's recruiting. What about radiation therapy? So adjuvant radiation therapy, again, the data is not exactly, it's limited, and the practice of giving radiation is center dependent. And so in this particular study, they actually have better outcome with radiation after surgery, especially if you're concerned about spillage of the tumor. So generally speaking, we do recommend radiation if there is a concern that the tumor was not fully resected and it's not R0. And so as far as surveillance, how often we survey patients, in the first 2 years, we do every 3 to 4 months. And then in the second 2 to 5 years, every 6 months. And then after 5 years is once a year. And this is just a summary of what I said. Based on the resection and based on the stage, you decide what to do: observation, mitotain, both, chemo, no chemo, radiation, or not. This was published in MD Anderson paper in 2016, and it's here for summary. What about advanced disease? Now we're talking more metastatic, recurrent, advanced disease. Again, surgery is an option because you want to debulk that lesion. Systemic therapy here is more of the discussion. Neoadjuvant chemotherapy, adjuvant chemotherapy, and targeted therapy. Radiation here is not just for the adrenal bed, but for example, if it's metastasis to the bone. So it's for palliative reasons. So the current adjuvant and metastatic, again, we go back to mitotain. Some people use mitotain because if it's killing any adrenal tissue in the body, it might be useful. The outcomes are not great, so that's why it's combined with chemotherapy. And the only study that compared chemotherapy, it's the FIRM-ACT study, that actually compared, it's a double-arm clinical trial conducted in ACC, comparing etoposide, doxorubicin, cisplatin plus mitotain with streptozin mitotain regimen. And the EDP was far more superior, but the outcome was not great. But that's the current standard of chemotherapy. And this is the outcome. So both are great, but EDP is probably better. There's a lot of trials that looked at VEGF inhibitors in these cases, and actually the yellow is progression of the disease, and the gray is a stable disease. So your best bet with this treatment is just stable. There's no improvement. And so using them alone is not enough, and now typically we use them on top of chemo plus mitotain or radiation. So this is just to summarize for metastatic disease what we do. You want to do cytoreduction surgery if there is any chance to remove that surgically, palliative radiation, and then chemo. If they don't have a response or progress, then alternative chemotherapy and ongoing clinical trial. There's a lot of ongoing clinical trial now looking at all these targets therapy, but none of them is very promising, including immune therapy, actually. There's an ongoing trial for immune therapy. But single agent is not working so far in any of these trials, or at least at the time of recruitment. Multi-agent therapy might be useful. So we'll know more in the future. Like I said, it's not exactly like thyroid cancer, so knowing the molecular target and trying to target that doesn't always translate to improvement in outcome, at least based on the current data that we have. So take-home points, the presence of adrenal mass with elevated glucocorticoids, precursors, and or androgen or precursors is very highly suggestive of ACC, especially if the images are suspicious. ACC patients may need formal genetic counseling, especially in the presence of family history of cancer. Detailed hormonal testing and staging are needed prior to any surgical resection because you want to see if this adrenal mass is suspicious, is there any metastasis? In a study that I recently looked at, more than half of the cases, endocrinologists were not testing for hormonal acting. Not necessarily because the patient went through endocrinology, because they sometimes go straight to surgery or oncology, and they don't always check hormonal profile. Open surgery is the preferred surgical approach for suspected ACC, especially if it's more than 6 centimeters. ACC has a high recurrence rate, especially if it has high mitotic figure. In cases of localized cases of ACC, post-operative images surveillance of the chest, abdomen, and pelvis needed every 3 months in the first 2 years, then kind of like less and less frequently if they're stable. Mitotain is approved to treat advanced and metastatic disease in ACC. It's not really useful for low-risk ACC. Mitotain use is associated with plethora of endocrine side effects. We mentioned the hydrocortisone story. It actually causes hypothyroidism, it causes dyslipidemia, and so much more. So I think people on mitotain should always see an endocrinologist. EDP mitotain is the preferred systemic therapy currently for advanced cases, but the response is not great. The role of immune therapy is still emerging, so I can't comment on that now because there are ongoing trials. Patients who progress despite chemotherapy can basically be enrolled in clinical trials. Thank you very much.
Yeah, I think once we give mitotain, do you use fluorocortisone also, or not with the hydrocortisone, or just give hydrocortisone alone? Because I have seen one patient under my care, before, and we have been using hydrocortisone with fluorocortisone also.
That is correct. So initially, the mitotane effect doesn't affect mineralocorticoid immediately. So it affects glucocorticoid, and they require replacement. And then few months later, and sometimes few weeks later, they have mineralocorticoid effect. And so yes, they eventually, if they continue on mitotane, then they will require fluorocortisone as well. And typically small dose.
Well, interestingly, that patient was 21-year-old female, and she presented with Cushingoid features.
Mm.
And she was resected. She was 7-centimeter tumor, but well capsulated. And I remember it because she was given for 1 year this treatment, and the father wanted to get her married, and she got married without the advice of the consultant. And then he stopped also this mitotane and everything, and she was, tumor free for next 2-3 years, and she delivered a baby also after that. It is rare.
Yeah, it is rare, but it happens. And actually, the current recommendation, if a woman wants to get pregnant, they need to be off mitotane throughout the period and up to 1 year before that. Okay.
Thank you, Dr. Sina, for the nice presentation, which was done comprehensively. Dr. Sina, you have to come again to receive your certificate, Dr. Sina. And you have to take the seat over the stage. Yeah, she will be back.